Hello, my name is Alex Fortenko, and for the next 5 minutes, I'm going to talk to you guys about doctors as innovators. Now, I want to start off by posing a scenario. Think about your last clinical shift, and think about a time on that shift when you were really, really frustrated. Think deep, think about how angry you got, how frustrated you were, and now think a little bit deeper, and instead of letting frustration take over, think about a solution. Is it maybe a better throughput process? Is it an innovation of some sort? Is it a device or a smarter electronic health record? And now think a little bit deeper, even beyond that. Do you know how to go about making your concept come into reality? Do you know how to execute, or are you continuously stuck in an ideas loop and unable to go forward? I would argue that most physicians are the latter. And as a result, we've given away our sovereign right to be innovators and leaders in this field. We've given away to others. And instead, we've spent so much time worrying about patient satisfaction scores that we've forgotten to take care of ourselves. And the physician-provider gap, the innovator-provider gap is ever widening. And rightfully so. Our specialty is ripe for innovation and disruption. There's also funding and money at stake. And other entrepreneurs, engineers, coders, they've spent their intellectual capital trying to make our industry the Uberized. And they've done a good job. In 2016, there were 230,000 digital and mobile health platforms available globally online. Venture capitalists spent $3.5 billion in the first half of 2017 alone making this come to reality. But where are we? Are we any better off? Is healthcare better and leaner and better for the patients because the venture capitalists have spent $56 million creating a device we have no use for? I don't think so. So I want to posit to you that we are the people that should be leading the charge here. We're smart, we're innovative, we think outside the box, and we know how to make critical decisions every single day. We should be the ones behind this. So a couple days ago, I had a young patient. She was in her mid-20s. She was a millennial, and she had palpitations, but she also had an Apple Watch. And so what we did is we tracked back, and we saw what her heart rate was, and she was pretty adamant and clear that she was actually sitting or maybe just walking kind of at a ginger pace whenever her heart rate would jump up into the 160s and the 170s. So she was asymptomatic in the ER. We observed her for a while. EKGs were okay. We created a nice outpatient plan for her and got her a cardiologist and a Holter plan for the next day. But when she left my ER, I thought, can we do something better? Can we maybe visualize this data in some sort of way? What if on top of the heart rate, the Apple Watch can also give us a single lead EKG, so I knew when she hit the door if she was in rapid AFib or SVT or just in plain normal sinus? And what if we can all upload that information and that visual data into her EHR, so when she goes to her cardiologist the next day, she actually has a diagnosis, and the cardiologist can focus on treatment instead of spending more time on diagnosis. I think we can do this, and I think we should be the ones leading the way. So to put my money and my time where my mouth was, I started something called mHealth Toolbox along with a couple of my colleagues. What we are is we are a physician-run group, and what we do is we try to get doctors more involved in clinical innovation. We work with small companies that are all venture capitalist funded and backed, but that have very limited backing and resources with doctors, so none of them are founded by physicians. And we get our doctors to play with the tools and devices and think about critically about innovation and then bring those skills back to their own clinical institutions in the hope of improving things. What we found was quite staggering. Most of the devices that we featured, even though that they were meant for ED use, had no implications and actually were harmful for our workflow and didn't make sense in our everyday lives. So when we leave these things up to others, they continuously fail us. So how do we go about making a change? The biggest thing is going to happen at a medical school and a residency level. So medical schools will have to accept students from more diverse backgrounds, from engineering and coding to maybe even business. Residencies will have to collaborate with other institutions that they have available to them, like business schools and public health schools, and test some of these devices before they hit the big time in our EDs. I think the most important thing to think about, though, is what we can do on a private and personal level on a micro scale. The biggest pain point for all of these companies is they can't get their device into the hands of the end user. We can be their bridge. We can go ahead and reach out to someone we know that has a startup and offer our clinical expertise, or maybe start enjoying the AMA Innovation Fund, which exists already. We can raise our hand when an innovation comes to our ER that doesn't make sense and doesn't fit our workflow. We can learn to code. We can learn their language. There's innovation fellowships at Stanford and TMC that we can all join. We must do this, because if we don't, we're going to be in the same place we are with our electronic health record. So thank you.